and I welcome you for our melanoma discussion panel here, and may introduce Professor Jesus Medina from Oklahoma City. He's an experienced head and neck surgeon, and we are happy that you did all this way to come here to Frankfurt, and not so far away, in particular directly from Frankfurt, from our university hospital. We welcome Professor Bergmann, Lothar Bergmann. He works as a clinical oncologist and is a very experienced physician and a professor of internal medicine. And the same with Professor Ulrich Keilholz, who is working in Berlin in the famous Charité at the Benjamin Franklin campus, and also as a medical oncologist and especially as a melanoma experienced oncologist. And we have listened to your talk. You come from Will Schwief, and he is directing the research of head and neck surgery, but he's also a practical head and neck surgeon. Myself, I am a superficial physician because I'm just a dermatologist. But in Germany, dermatologists, as well as in Switzerland and in Austria, they also take care for skin melanoma. They usually, in their big departments, have also their own dermatohistopathology laboratory. They do their own surgery, and interdisciplinary with the other colleagues, we also follow the patient. But melanoma is a very unpredictable, very capricious tumor. It's, let's say, the bad guy, the black sheep among all solid tumors. And if skin melanoma is the bad guy, then head and neck melanoma is an even more bad guy. And mucosal melanoma is incredible bad guy. And you have heard that by your talk. And I thought that we structure a little bit the discussion. I will present you some, perhaps we can go one back. Yeah. Some statements which just appeared, published by the different groups of the German Cancer Society and the working groups. And also Professor Keilholz, you can see here, he also participated as a medical oncologist. And from our department, I myself participated as a dermatologist. And these guidelines now appeared in melanoma research in January 2008. And I will just bring up some statements for the skin, and we can discuss it if it's true or if it holds true for the head and neck. And let's start with a statement: an excisional biopsy is preferred. It's very simple. When we see the patient, we do the primary diagnosis, but we have heard the special challenges in the head and neck area. Are there exceptions? On the other hand, if you do not excisional biopsies, if you just do incisional biopsies, what are the drawbacks? Would you perhaps comment on that question, Professor Medina, because you are, as a surgeon?
Well, there is no question that an excisional biopsy is preferred when possible. And we know that there are limitations because of mainly the size of the lesion and the location of the lesion sometimes that preclude our ability to do an excisional biopsy. For instance, melanomas in the scalp that can be very extensive. To excise the lesion to make the diagnosis, then you have to undermine a great deal of scalp to bring the edges together, and becomes impractical, interferes with the definitive treatment sometimes. So in those cases, a well thought out and well done and properly oriented incisional biopsy, such as a punch biopsy or an incisional biopsy, is the thing to do. And I don't think that there is any convincing evidence that doing that harms the patient in any way.
What is the information you want to get out of this biopsy, Professor Temman, perhaps?
So I think I completely agree, but we have to be very careful about the orientation of the excision biopsy. And I think some issue we can have if when the path analysis of excision biopsy don't answer the question what we want. I say, okay, I don't know how did you take that off, and it's far here, it's close, and we don't know how deep is it, and sometimes it's occur. So we have to be very careful with that.
Perhaps on the outer skin, it's a challenge to have the deepest spot in a large lentigo maligna melanoma to assess the Breslow thickness, or if it's still lentigo maligna as an in situ melanoma, which can be regarded. On the mucosal membranes, you mentioned anyway the patients, they are above 4 millimeters. They are a special stage already, and therefore it might not be as important. Yes?
Yes, in that regard, I think if there are any dermatologists or any other practitioners in the audience that may be tempted to perform a shave biopsy of a pigmented lesion, I think that's what causes the most problems, because you can't assess the parameters that you were asking about, which are essentially, of course, the diagnosis of melanoma, and the two most important things for prognosis and treatment planning are the thickness of the lesion, the level of invasion, and the presence or absence of ulceration. And if we do a shave biopsy, oftentimes we cannot get an accurate assessment of the thickness of the lesion.
I agree with this. So no shave biopsies, but incisional biopsies are possible, and perhaps we can have the next. That is the statement, at least in these guidelines. Incisional biopsies should not be performed when an excisional biopsy is possible. I think we can agree with this. Among exceptions are large lentigo maligna of the face or mucosal lesions. That's just what we said. And we also made a statement how to do it and what is important with this. And you also mentioned already there is no disadvantages for patients with an incisional biopsy. That is very important, so it's not a drawback with regard to the prognosis of the patient. And this has a level of evidence of 3, this statement. Now we come to the second point, treatment of the primary tumor. Once you have the diagnosis, the primary treatment should be surgical excision. That is what all the guidelines tell us. But what about lentigo maligna in the face? What about in situ melanoma of mucosal surfaces? Are there alternatives to this basic statement? Who wants to comment? Yeah.
Well, I could begin by saying that we have to remember that what got us, I think, in the direction of using radiation therapy for melanoma again was the initial work by Harwood when he was in Toronto years ago, treating lentigo maligna and lentigo maligna melanoma with radiation therapy, and his results were outstanding. So I think little has been said about that in writings of late. But every once in a while, I do prescribe radiation for the treatment of a primary lentigo maligna melanoma in an elderly patient who's otherwise at high risk for a surgical procedure.
I think that's a very important consideration. Further comments?
So on mucosal melanoma in situ, I think it's still a controversy. When in our institution, some of the surgeons say, okay, I remove all the mucosa of the sinus and the nasal fossa, and some of us say, okay, just follow up. So there is still controversy and nobody knows what to do.
Even in situ melanoma?
Yeah, because sometimes it's very extensive. And so if I take that off at what point, next 2 centimeters you will have the same. If you do a biopsy, you will find the same.
Are they frequently amelanotic, that they don't black sheeps?
No,
but white sheep?
Because when it's amelanotic, you don't see it. But what we want to remove is a brown spot everywhere. Yeah. But I'm not sure that is very useful.
Willy Keilholz?
Well, if you put that statement that excision should be done, the question is what is the limitations, and that's obvious, that may be site or size of the lesion, but what are the alternatives? You mentioned radiotherapy in certain cases, and what is a more novel alternative is maybe a local treatment with imiquimod, which can be an alternative in certain cases where excision is impossible. What do you think about that? That's more a dermatologic treatment.
Yes, perhaps I can comment on that with the next few slides.
Okay.
treatment of lentigo maligna with topical imiquimod. We are really spontaneously here. We don't. It's not absolutely.
I didn't know that.
So far we didn't know it, but I expected it, so I put that on as the next one. And in fact, complete response in 33% of patients in such initial studies. This is a patient of ours. And he refused surgery, and we did a biopsy. It was a biopsy-proven lentigo maligna. And after 2 weeks, he had a local inflammatory response. And then a couple of weeks later, it all disappeared. And he is still now, 1.5 years later, still in remission, and is very happy, of course, with this result. But an alternative would have been in an older patient. He was still quite young. An older patient would have been radiotherapy. And we published together with our maxillofacial surgeon, Professor Kovac is also here in the audience, this case with a patient, 67 years old female, melanoma heart palate in 2002, prior to surgery, cisplatin in the left maxillary artery, partial maxillectomy, plus 6 nodes which were removed and were negative, adjuvant interferon treatment, and then local recurrence, again with partial maxillectomy with negative resection margins, then again relapse, residual tumor, despite multiple gingivectomies and mucosectomies. So then we started with the imiquimod, and all this disappeared. And there are now 15 months, I think, of follow-up. So, and the other statement, I also expected that, the radiation therapy. That is again from these guidelines in older patients with multiple systemic diseases or poor surgical risks. Primary radiation therapy, soft radiographs. We have in Germany, for instance, this DAMO-PAN system, or electron beams can be considered. Level of evidence, however, is only 4. And the local control rate of lentigo maligna is over 90%. The level of evidence here is 3. And the results we see are fascinating. That is, from the cosmetic point of view, always excellent. The drawback, of course, it's when it's in the scalp area. You agree with this?
Yeah, for me, it remains a little bit unclear for a special patient, which is the first choice for treatment for lentigo maligna. Is it excisional surgery, or is the local therapy with imiquimod a real alternative? Or should this only be restricted to those with comorbidities or older patients? I think we don't have long-term results up to now concerning the overall survival and possible overall survival benefit. But indeed, I think we must ask this question, are these alternatives, or must we still say excisional biopsies has the first choice?
Would you comment?
Well, I would have to say that in a lentigo maligna melanoma, or a lentigo maligna, it's often extensive lesion, difficult to assess with an incisional biopsy in those cases. So I think that an excision of the lesion and proper evaluation of it is the preferred treatment. And I would like to, at least in my practice, these other alternatives come second to that, and are usually prescribed when there are comorbidities that preclude surgery.
It's also our first choice is always surgery when it's possible, surgical removal. So perhaps we continue with the next issue. You also questioned that in your talk, in your introductional presentation. There's a statement in the guidelines, 1 centimeter for tumor thickness up to 2 millimeter, sorry. For 2 millimeter or higher tumor thickness, 1 centimeter for tumor thickness up to 2 millimeter, and 2 centimeters for higher tumor thickness. That is level of evidence 2. This recommendation, since we have many randomized prospective studies comparing larger and smaller resection margins, in particular with regard to cutaneous melanoma. Now, again with lentigo maligna, we have discussed that, and also with in situ melanoma of mucosal surfaces, alternatives to mucosal scenarios where you don't